the World Psychiatric Association, the section on evidence-based psychiatry, in a collaboration with the section of Mental Health Institute of Scientific Research, Pan-Hellenic Medical Association, and International Society of Neurobiology and Psychopharmacology. So during this webinar, I will be moderator. So if you have any questions, you can write me directly here in Zoom platform, or contact me via my email at wróblewska@.lv. So, and we will start with the greetings. And the first, I would like to give words to President-elect of the World Psychiatric Association, Afzal Javed. So please, Afzal.
Well, thank you very much, Jen. Good morning and good afternoon to all the participants. The greetings from my own side as well as from World Psychiatric Association. I'm really pleased that this is the first webinar which we are going to organize under the platform of a working group on evidence-based psychopharmacology, and our WPA scientific section on evidence-based psychiatry is taking the lead to run this program, which we hope that we will be continuing during the next 3 years. I'm personally grateful to Kostas and Jelena, who are the chair and the secretary of the section, for doing all the homework and the hard work in terms of collecting so many people from the globe. One of the main objectives of these webinars would be to keep our audience updated about the current psychopharmacological updates, advances, and any new directions in the field of clinical treatment of psychiatric disorders. I can see from the list very impressive names from Asia, from UK, Professor Mohan is there, and there are many other people who are joining this particular webinar. This effort was initiated as an interzonal activity, and as many of you know that WPA has got 17 zones. And for this particular activity, 3 zones are actively participating. These are zones 15, 16, and these zones are led by Professor David Naditi from Kenya, Professor Khalid Mufti from Pakistan, Brigadier Raju from India. I'm sorry to inform you that Brigadier Raju will not be able to join us because he had a personal tragedy in his family. He lost his young son about 2 days ago. So with the permission of the moderator and chair of the section, Kostas, may I request that if we can have 1 minute silence to remember and to join the grief of Professor Raju.
Of course, Afzal.
Well, thank you very much. And coming back to the importance, this is the first initiative of WPA that we have involved 3 zones from South Asia, from Middle East zone, as well as from Africa zone. And thanks to you, Kostas, for leading this particular activity, which will certainly, we will continue during the coming years. So with these thanks, I hand over the proceedings to be started by our moderator.
So thank you, Afzal, for these words. And on behalf of all of us, we express our deepest condolences to Dr. Raju and to his personal loss. I would like to introduce a person who will say some greeting words. And this person is a Professor David Ndetei, and he is a representative of East and South Africa. So, Professor works at the University of Nairobi, Kenya, and is the founder and director of the Africa Mental Health Research and Training Foundation. His passion is in developing services that have the potential to reach critical masses using the limited resources available in most communities in low and middle income countries. This includes collaborations with high income countries for technology transfer for evidence-based practices. So please, Professor, so say some words to us.
Lena, unmute his microphone.
So unfortunately, I can't see the option to unmute. So I think David can unmute self as well.
Ik kan niet ook serieus bij iets, maar
You can unmute yourself. Professor Ndetei, you are unmuted. You can speak.
I am trying to unmute myself.
You are unmute.
I am unmuted. Can you hear me?
Yes.
You can hear me now?
Yes.
Oh, okay. Thank you very much. I just want to say I am very grateful to the organizers of this webinar. It's great that we can use technology to reach as many people as possible who need these services. And I am particularly grateful to our president-elect. I know he has done a great job in trying to put us together. So I am happy that we are able to do this, and I think we are honored that Zone 14, where I represent the WPA, is organized is. And I do hope that many people from the several zones that are represented will benefit. There will be eloquent and good presenters from these areas, and that all of us are going to benefit. In the long run, it is the consumers of the services who will benefit most. So thank you very much, and look forward to very interactive webinar. Thank you.
So thank you, Professor Ndetei. So, and I would like to present Professor Khalid Mufti, who is a representative of Zone 15, which is covering Central and Western Asia. So, Professor is International Distinguished Fellow of American Psychiatric Association. He's Chairman Horizon Peshawar, Pakistan. He's Chair Executive Ibadat Hospital in Pakistan and former Dean Principal in Khyber Medical College in Pakistan. And he has a special interest in disaster psychiatry. So please. So, Professor, you also have to unmute yourself.
Yeah, can you hear me now? Because I have. If you all hear me, thank you very much, Jelena. And I think I'm really impressed by the hard work you have done and your section. I'm particularly, I have more interest because of my zone, which apparently Iran and Pakistan, and even in between Afghanistan comes. In all these places, people, there is a unjudicious use of psychopharmacological drugs. And that is because, number one, there are not many psychiatrists properly qualified, physicians who are not well equipped with the latest knowledge or latest revelations, updates about psychopharmacology. And the third thing is then many people can get the medicine without any prescription. As a result, there has been many difficult situations, heterogenic problems in all these countries. I'm really grateful to you all. I'm grateful to the President-elect, Mr. Afzal Javed, all of you, and I think I'm eager to listen to the august speakers here. Thank you very much.
Yeah, I think you need to unmute yourself.
Yes, thank you, thank you. Yes, no, I've noticed.
Jelena, may I just interrupt? Professor Dalal, who is president of Indian Psychiatric Society, will say a few words on behalf of Professor Raju.
Yes, exactly. I just wanted to introduce him right now. So please, Professor Dalal.
Professor Dalal, have you logged in?
Yes, sir. Yes, yes.
Yeah.
Thank you. Am I audible? Thank
Yes.
you, Afzal sir, President-elect WPA, and the evidence-based psychopharmacology section of WPA. And thank you, Jelena and Professor Kostos. And the three zones, this is, as you have said, this is really remarkable that the three zones are working together and presenting a wonderful webinar. I am grateful to Dr. David and Dr. Khalid representing zone 14-15, and I am representing Professor Raju as zone 16. This is really a very good, I would say, very scientific webinar on evidence-based psychopharmacology. And we all are not only satisfied with the response criteria. I mean, we all know level 1, 2, 3, 4 evidence levels. So we would like to hear from the presentators that going beyond the response, that is, what is the remission criteria actually, and how to achieve remission, because the clinicians, they are really they want remission in different illnesses. So with that few words, I would again congratulate Dr. Afzal Javed and the representative of this different zones, as well as the WPA section, and I hand over to Dr. Jelena. Thank you.
Thank you, Dr. Dalal, for these words. I want to ask Kostas whether Dr. Anastasios Exadaktilos is here.
Unfortunately, he had an urgent work to do. He is president of the Greek Medical Association, and these times are rather difficult and very busy for politicians. I think he will join us later, maybe in the interval between the two speeches, so we can proceed with Argyris.
Yes, so then we'll start with the lectures, and I would like to introduce Professor Argyris Stringaris, who is a professor of psychiatry at Georgetown University. He is senior investigator and chief of Mood, Brain and Development Unit at National Institute of Mental Health. He also is a president-elect of International Society for Research in Child and Adolescent Psychopharmacology. So please, Professor, the Zoom platform is yours. So kindly share your screen, your PowerPoint. Great, we can see it.
Perfect. It is a tremendous honor and pleasure to be presenting at this conference today. I'm particularly grateful to the president-elect of the WPA and Professor Foundoulakis for inviting me to give this talk on child and adolescent psychopharmacology with a focus on child and adolescent depression. I would like to acknowledge the input of my good colleague, Ioana Duca, who's with me at the NIH. So what treatments do we actually want in psychiatry, and what treatments do we actually have? So before we get to that, let me give you an overview of my talk. So the first thing I will do is to present about depression in children and adolescents, its definitions and challenges. I will then give you an overview of treatments, psychopharmacological treatments, before I move on to talking more specifically about medication treatment, proposed mechanisms of action of antidepressants, adverse effects, and talk about the suicide debate, and then how to manage treatment-resistant depression at the end. So let me start off by saying, what treatments do we want and what do we actually have? And I think for anyone who's treating patients, anyone in medicine, there's some examples of achievements in medicine in the last few years. One of my favorite ones is chronic myeloid leukemia, which used to be a lethal disease. So chronic myeloid leukemia has a genetic defect, which is a chromosomal translocation. Many will be familiar with the Philadelphia chromosome, which results in an aberrant protein, fusion protein, BCR-ABL, it is called. And it was one of the miracles of modern medicine that a way was found to block this very protein. And this was the drug imatinib. And imatinib brought about a revolution. It was specifically designed to treat the genetic defect in CML and revolutionized patient care, saved lives. And nowadays, chronic myeloid leukemia is mainly a chronic disease rather than a deadly cancer. So this happened over decades, if not a whole century. How is it in psychiatry? Well, in psychiatry, we have messier phenotypes, and key tissues like the blood are unavailable. So depression is quite a messy phenotype, as I would say. In terms of genes, well, in depression at least, the genetic contributions to intra-individual variability cover about 30% of the variants, not terribly much. And we also have environments, and the environments seem to play a more important role in our disorders and our common disorders than they do in simpler disorders like or diseases like chronic myeloid leukemia or other monogenetic disorders. And there's no 1 or 2 or 3 or 4 or 5 genes or proteins. There's much more than that in depression, as we of course know from the genetic studies. And we also face the problem of normativity. It is very easy to say, I want to kill all cancer cells, but it is sometimes difficult to know what the boundaries are between what is normal and what is pathological. And over-treating, we heard before that iatrogenic problems are quite important in their own right. So we face unique challenges. Depression, you could easily define it as meeting at least 5 out of 9 criteria, and everyone knows those 9 criteria. I list them here. So it's easy to define ostensibly, but actually, and it is potentially lethal. We know that adolescents with major depression are up to 30 times more likely to die of suicide. It has a cumulative prevalence of at least 10% by age 16, and it's a global problem, leading cause of years lived at disability. And you can see this here. Unipolar depressive disorders account for most disability-adjusted life years in this age group, more than road traffic injuries, iron deficiency, anemia, infections, and all sorts of other things. And this is worldwide. And of course, it affects more females than males, certainly from puberty onwards. But depression is heterogeneous. This is a very simple way of thinking about it. You need to have at least 5 out of 9 symptoms. But if you do the proper combinatorics of how many syndromes those 9 symptoms could give, you end up with 9,197 different depression types. So no, it'd be very hard within a clinic even to say that 2 of your patients have the same depression. The symptom constellation could be very different. This creates difficulties, of course, when you think about etiology and treatment as well. So depression is a multifactorial illness. Unlike chronic myeloid leukemia that I was presenting before, it has genetic inputs, environmental inputs, things like active gene-environment correlation, so genetically encoded characteristics of the individual that elicit potentially depressogenic environments, passive gene-environment correlations, situations where for example, a depressed parent, a depressed mother, not only passes her genes with a high probability, of course, to her children, but also the environment she might be creating, the father might be creating by virtue of being depressed. And of course, gene-environment interactions. So different genetic makeup may confer differential sensitivity to the environment. So it's quite complex and it's hard to know where to start with this actually. Remember also that depression is a developmental disorder and the peak of its cumulative incidence happens around adolescence and young adulthood. It's this very steep curve here. This is aging years, this is the cumulative incidence. And you can see here that there's a very steep slope, which then kind of plateaus out here. So what's happening during this time? And more importantly, are youth and adult depression the same thing? There is evidence that there are different mechanisms. There is certainly continuity, and someone with adolescent depression is, of course, much more likely, about 2.5, 3 times more likely to be depressed as an adult if they have depression in adolescence. But there's a lot of desistance as well, so non-continuity. And of course, there are different responses to treatment, and I'm going to be talking about a lot of that further down the line. That treatment in adults and adolescents seem to be different. So these are all challenges that we're facing when we're thinking about treatment. So let me get to the second point then, which is give you a simple overview of the treatment. So some definitions first, which will be very familiar. You'll be very familiar with. What remission is, minimal symptoms of depression after treatment. Response, substantial improvement in depression symptoms with treatment. Greater than a 50% improvement in depression symptoms, typically, that's the definition. In whatever instrument you're using, the MADRS in adults, or something else of your preference. Then there's partial responses and there's no responses. And we'll talk about all these as we will about treatment resistant and treatment refractory depression. So, with those definitions in mind, let us think a little bit also about what we're trying to achieve. As clinicians, we very often are primarily interested in reducing symptoms. And that's, of course, very laudable. You know, that's what you're meant to be doing as a doctor. But you're also meant to be thinking, particularly if you're a developmental psychiatrist, about a few other things. Life satisfaction is one, successfully meeting developmental milestones. And that includes social and other things like academic milestones. And then, you know, sustaining the transition, which is quite difficult often from adolescence to adulthood. It is not clear that medication helps us achieve all this in the way we would like to at the moment. So first, what is the treatment of depression? I summarize it here. The first line is either CBT or another psychotherapy and SRIs. Then there's a combination treatment, and then other medications such as SNRIs, augmentation, right down to ketamine, TMS, and ECT. And I will try to cover all of these. So let's start for the purposes of our overview with the National Institute of Clinical Excellence guidelines, not because I think they are necessarily perfectly correct or that they should be applied everywhere in the world in the same way, but just because it is a principled way of thinking about these things into which a lot of effort has gone. I personally don't necessarily agree with all that the NICE guidelines say about depression, but it's a good starting point. So they say if you have mild depression is defined in the ICD, or mild depression, as you clinically would deem it to be mild, you could just do watchful waiting, and we'll talk about the reasons for doing that. Or you can do some kind of intervention in groups, such as group CBT, and then take it from there. And this can be, according to NICE, done in tier 1 or tier 2. So for example, at the GP level. There's not a tremendous amount of evidence on, digital group CBT, but hey, it's probably also not terribly harmful, though there can be a discussion about that. Now, if you have moderate to severe depression, according to the NICE guidelines, if you're very young, NICE say do family-based IPT or family therapy or individual CBT. I must say that the evidence for family-based IPT or family therapy in 5 to 11-year-olds with depression is not impressive. So I just want to be clear about it. So people who are doing this, it's not completely unreasonable, but you shouldn't also think that this is a substantially evidence-based treatment. When it comes to 12 to 18-year-olds, again, the preference of NICE is to start with individual CBT. I'll be commenting on individual CBT, but they say, okay, and at this stage, you can add fluoxetine. And you can see that the NICE guidelines just say add fluoxetine. And we'll say why in a minute. So now, if depression is unresponsive to treatment, they say, okay, do intensive psychological therapy, whatever that means, maybe more sessions during the week, and you can then think of adding another SRI or augmenting with an antipsychotic. Okay, all this seems reasonable, but there are many caveats that we need to discuss about this, and I'll go through them step by step. So, the first line treatment is CBT for depression according to the NICE guidelines. I'm not going to go into depth about CBT because this is a psychopharmacology talk, but you all as clinicians will come across this dilemma very often and people will ask you about it. So CBT has some evidence in its favor, there's no doubt, and combination treatment, CBT plus fluoxetine, was superior in some ways to fluoxetine treatment alone. But there's no additional benefit of combined treatment over medication alone in the most severely depressed patients. Moreover, adding CBT to medication in a pragmatic trial, such as that one that was done by Ian Goodyear and his team back in the mid-2000s, the ADAPT trial, didn't seem to confer a particular benefit. And the overall effect size of psychotherapy for depression, including CBT and IPT, is poor, is at best 0.3 as it codes the effect size. And I want to point out here that, and I'll say that later on again in more detail, there is no equivalent of placebo in most cases of CBT trials. So CBT is good, I do it with my patients, but beware of that when you explain things to parents or adolescents, children and adolescents themselves about treatment options. Okay. Let's go now to medication treatment proper, efficacy and the placebo effect. So this is from Andrea Cipriani's 2016 meta-analysis. What you'll see here is you see that the size of the circle here represents the number of people randomized into trials, into RCTs, randomized control trials. Most people have been randomized into placebo, of course, because most trials are placebo-controlled trials. Then the next biggest circle here is fluoxetine. And that reflects the fact that fluoxetine has been around for a long time and many trials have been done with it. The rest are much more rarely studied in relation to child and adolescent depression. Okay, and most of the studies have compared fluoxetine with placebo. So we have the most data about fluoxetine, right? For example, there's terribly little about amitriptyline or, nefazodone or drugs like that. Okay, what do we learn? Don't be put off by this slide. It basically gives us, it basically gives us a good overview of the efficacy of different medication. So look at the lower half of the square, below the diagonal square cells here, and anything that is significant is bolded. And what you can see here, again, this is from Andrea Cipriani's meta-analysis. Fluoxetine, when compared to placebo, is the only drug that has a significant effect in this network meta-analysis. And you can see the lower the number, the better here. You can see that fluoxetine versus placebo is the only drug with a significant difference, as I said, in this meta-analysis. In the network meta-analysis, there were other comparisons, including between drugs, but they didn't reach significance, which is not a terrible surprise given the sample size included. So because of this and other meta-analyses that have been done, the NICE recommends fluoxetine primarily. And this is also reflected in the FDA guidelines that says, okay, well, please use fluoxetine, or the other licensed drug is escitalopram, and we'll come to that. So now, how effective is the treatment of depression in children and adolescents? Is it ineffective, as many people say? Well, actually, the response rate is not that bad. It's about 60%. So serotonin reuptake inhibitors have a response rate of about 60%. The problem is that in children and adolescents, we have a very high average placebo response rate, about 45 to 50%. So therefore, the numbers needed to treat, which is nothing but the inverse of the difference between the placebo response and the SRI response rate, ends up being, you know, around 10 or something like that. So there's a tremendously high amount of placebo response. And I want to emphasize this because many people would say, oh, SRIs don't work. Well, it depends on what exactly you mean. And I want to therefore spend some time talking about the placebo response in youth, if you don't mind. So, is the placebo response something unique to depression? Well, no, it isn't. This is one of my favorite early 2000 studies on the placebo response in blood pressure, in medication, in hypertension. And what you can see here is that in the entire group of, an RCT that was done to treat depression, there was an active treatment group that has a 58% rate of reducing blood pressure compared to a placebo group. And you can see here that there was a 30% response rate of hypertension treatment. So this is not, how do you feel? Well, you could get it wrong. This is, I take my sphygmomanometer and I measure your blood pressure. And you can see that there's a 30% response rate in the placebo group. Not only that, but, the placebo side effects rate, right? The discontinuations from the study as a result of adverse events is at least equal to the active group, if not higher, if that makes sense. So placebo responses don't seem to be unique to depression. This is one of my other favorite studies, and a bit of a joke. This is from the 70s, and they told weightlifters, bodybuilders at the time, okay, we're going to give you steroids. And back then, people had a lot of latitude, it seems. Researchers had a lot of latitude in terms of their subject. They told them, I'm going to give you steroids. Okay, so they had a training period without steroids, and then they told them, I'm going to give you steroids, but they actually gave them placebo. And what you can see here, this is quite dramatic, you can see that in terms of the kilos they could lift, so a very physical thing, right? Squatting, bench pressing, and whatever people do, you can see that this is the regression line when they were just training. This is what happened after they were told that they're on anabolic steroids, but actually weren't. They could lift more, which I find extremely interesting, of course. It's very hard to do such a study again, of course. Now, not only that, but there is some evidence that the placebo response is in general higher in youth than in adults. So this is a meta-analysis in drug-resistant epilepsy, partial epilepsy, and the treatment effect was significantly lower in children than in adults. Okay, and the difference was related to an age-dependent variation in the response to placebo. This is not confined to epilepsy, and it seems to be the case in depression as well. The reasons for this remain elusive, and we can speculate, but it's just important to know. So it's not a specific property of adolescent depression, but it's quite marked there at child and adolescent depression. Also, I'm going back now to what I was telling you before about psychotherapy trials. What is entailed in the placebo response? It's the placebo effect, it's standard of care, and spontaneous remission. Okay, so beware when you're comparing to psychotherapy trials that compare against what? Waitlist control, right? So that's not a placebo, of course, right? So the thing is that there is a lot of spontaneous remission in depression as well, and particularly in adolescents. So this is something we wrote, a commentary we wrote in Lancet Psychiatry. 53% of adults with untreated depression show improvement in 12 months in a study that was done in Australia. This is even higher in adolescents. So imagine what would happen if you recruit someone into your study who had a single episode of depression. You said, okay, I'm going to treat you now with fluoxetine or whatever. Well, they might spontaneously remit. So they would spontaneously remit with placebo as well. This was not my phone, so there may be someone who needs to mute themselves because I could hear the beep of the phone. I don't mind it, but others may. What is the placebo response? So this is from a meta-analysis that was done by Bridge and colleagues back in 2007. So what it tries to see is the proportion of people who respond to treatment. And it seems, at least in some of the studies, the placebo response was higher, i.e. the differentiation from the active medication, the red line here, was smaller when the severity was low. By contrast, if the severity of depression was higher, like in this end, there was a clearer differentiation between the two. There's a similar phenomenon observed in adults, although there have been conflicting results in meta-analysis in adults. I'm aware of that. So, but it's interesting. The other interesting finding was that the more study sites are involved in a trial, the higher the placebo response. So you can see that when you have very few studies, very few study sites, like one study site, there's a big differentiation. The more study sites you have, approaching 55 or whatever, the lines come closer to each other again, i.e. the placebo response is higher. All right. There's another aspect that we must take into account, and this is a fabulous paper written by John Walkup in 2017 in the American Journal of Psychiatry, saying that, hey, actually it was not Walkup at all, it was just him writing it, if I recall correctly. And he said, if you differentiate between industry-funded trials that tend to have many sites as well, and NIMH-funded trials, the difference between active medication and placebo varies. So it's much bigger in NIMH-funded trials as opposed to industry-funded trials. The industry-funded trials tended to be more closely together. You can see it here by comparing these two columns for industry-funded trials versus NIMH-funded trials. So this is another interesting aspect. Again, lots of explanations here. We can go into details about that if one likes. So let me go to the next point, though, which is the proposed mechanisms of action of common antidepressants, commonly prescribed antidepressants. Well, SRIs, as we've said, fluoxetine and escitalopram are approved. There's better evidence of efficacy for fluoxetine. We said why before, more studies. Proposed mechanism, maybe that the long half-life of fluoxetine plays a role. It's unclear. There's recent evidence that there is greatest treatment-related improvement early in treatment. That may be predictive of overall response, and I'll show you some slides about that as well. So fluoxetine, as you know, has a number of interesting properties. One of them is that it has a very long half-life, and the half-life gets longer after you start taking it. Now, it's a shame that I can't deliver this lecture and see you all properly, but I would be asking you, what are the pros and cons of a long half-life, right? Well, great thing about a long half-life is you don't have a discontinuation syndrome. You're less likely to have a discontinuation syndrome, right? That's fantastic. What's the downside of it, though? Of course, if I were to make you manic by prescribing you a long half-life antidepressant, it would take me a long while to get you off it. And if I had to start an MAOI from starting with after fluoxetine, I would have to go for 5 weeks without fluoxetine and then start you an MAOI. So there are downsides to it, but it has a very long half-life, and it's also a very potent inhibitor of hepatic enzymes, right, CYP3A6. So that's very interesting. Now, the proposed mechanism of action of SSRIs is something we learn at medical school, right? reuptake of serotonin at the synapse, and increased serotonin cascade of interrelated processes. This is a plausible, hypothesized mechanism, which, with evidence from preclinical studies, we cannot demonstrate this conclusively in humans. So, and there's actually reasons to believe that it may not be the entire story. There's a number of reasons for that. SSRIs, and that's kind of a newer theory, the neurotrophic theory, that SSRIs may increase brain plasticity. There's changes in neural proxies of plasticity, such as and brain-derived neurotrophic factor secretion, but generally be cautious in interpreting such findings. Unlike in research like in chronic myeloid leukemia, where you can just take blood cells and experiment with them and show these things much more clearly, we can't necessarily extrapolate these findings with the rigor we would want to into humans. So I'm just putting this here, and I highly recommend Kath Harmer's paper from 2019 that gives an overview of the mechanisms of action of antidepressants. This is kind of the complex pathways involved in the neurotrophic, in the putative, I hasten to add, neurotrophic theory of depression that include increased BDNF and new AMPA receptors that are being generated. So it's all very interesting, but there's no definitive proof of this. There's other proposed mechanisms, such as the fact that SSRI may normalize the inflammatory response that is occasionally observed in depression, or possibly, again, we don't know enough about this. And there's also conflicting findings with this. There's no definitive evidence again whatsoever, and I wouldn't make a big proclamation about these things yet. This is not to say that it is not important research. It's just to say that we need to be cautious in what we communicate and not build up too big expectations. Another very interesting finding that comes out of, again, Kath Harmer's group, Professor Harmer's group from Oxford, is that there are early cognitive changes that happen with the prescription of antidepressants. So there are biological changes that may be happening in a matter of hours. Mood improvement may take a week or two or even 3, but early in treatment, within hours to days, and even after a single dose, there seems to be a positive shift in bias, both at the behavioral level and at the neural level. One of the famous examples is the reduced bias to angry faces after a single prescription of even a single dose of an antidepressant. I think the first example of this was reboxetine. So this is quite interesting and may explain a few interesting phenomena, such as timing of onset of action. So those cognitive changes seem to happen very early on, even after the first dose, apparently, or at least there's evidence for that. And that may explain why in some people we see that the timing of the antidepressant response is not the 2 to 4 weeks that one is taught at medical school, but actually onset of action within 1 week. This is Andrew Nierenberg's famous paper, from the early 2000s again. Over 75. So by weeks 2, 4, and 6. 55.5, 24.7, and 9.3% of people have responded respectively. The bulk of the people responded within 2 weeks. This is a meta-analysis from people in Oxford. And again, you see here that treatment with SSRIs is associated with symptomatic improvement in depression by the end of the first week of use. And then it continues decreasing, but the bulk of it happens early on, which is quite interesting. Okay, what are the adverse side effects of SSRIs? Well, there's the usual stuff that, again, you'll know from your own work and from your conversations with patients. So I don't need to emphasize these much longer. GI tract motility, the sexual dysfunction that we rarely ask about, and that's not good. Increased appetite, and all sorts of other kind of transient phenomena, such as the agitation. The true estimation of rate of side effects remains challenging, of course, for various reasons, including reporting biases. There's the issue of activation, so hyperactivity, impulsivity, insomnia, and disinhibition, which is associated with treatment in young people and happens early on, and one must look out for it, and you would want to differentiate this from an acute manic episode. And as I will be saying in a few minutes, you definitely want to make sure that you do not cause iatrogenic suicidality. There's a sexual side effects that are not well understood in young people, and as I said, clinicians often avoid asking about them, which is bad actually. So suicidality. You all know probably about the big black box warning, right? Significantly higher risk of suicidality, it was said, for paroxetine and venlafaxine compared with other serotonergic antidepressants in some studies. So there was this black box warning. FDA said, okay, beware of the possibility of increased suicidality. It is crucial to say here, and I'll show you a slide on this, that no single suicide was reported happened during any of these antidepressant trials. And in fact, if anything, there was an inverse relationship between rates of SRI prescriptions and rates of suicide in the adolescent population. Again, there will be a slide on this. And there's no increase in suicidality in some of the newer meta-analyses. As often with meta-analysis, it also depends on how exactly you chop what data exactly you decide to use. So suicidality and related, smaller numbers favor the column. So you can see here, this is fluoxetine now, right? And this is placebo. So where these two meet, fluoxetine and placebo, so this 0.9, you can see this is not significant. There's not a significantly higher rate of suicidality with fluoxetine. And this happened these are kind of big trials. So we can say with some confidence that the suicidality is not increased. I would still be quite cautious. Again, this is from the Cipriani meta-analysis. Same doesn't seem to be true for venlafaxine, which you can see down here. So it's probably not a good idea to prescribe it, certainly as a first line, or if you're not monitoring suicidality. So I would be cautious with that, to be honest. So I want to, there's a brief detour on some simple math on interpreting zero numerators. If you have 0 suicides in 1,832 patients who were in trials on the placebo, on the medication arm for antidepressants, how confident can we be that it is indeed 0? What is the upper limit? So for this, you use the rule of 3. This comes from a paper that I highly recommend to everybody to read, the Hanley and Lippmann-Hand paper from 1983. And basically, you can approximate that by saying that is by the rule of 3, which is 3 divided by the n, the number. So, and you end up with an upper bound of the confidence interval of about 0.2%. Okay, it's 0.2 in 100, if that makes sense. So that's very low as a risk, and I think it's very similar to what you would get in placebo. Okay, so no actual suicide, but increase in suicidal ideation and behaviors. Now, as I said, in ecological studies, and it's always important to beware of drawing inferences, to be cautious of drawing inferences from ecological associations, more SSRI prescriptions were associated with lower suicide rates in children and adolescents. Now, this can be confounded, but I'm just putting it out there as kind of stuff that one needs to think about. So I think the bottom line is, if you're a clinician and you prescribe SSRIs, don't just prescribe an SSRI to an adolescent and just let them go and say, I'll see you in 6 weeks. This is not a good idea. Okay, and if you have to do that, well, you need to make people aware in their surroundings, like the parents or friends or the person themselves, about the potential problems with prescribing SSRIs. So long-term considerations in children and adolescents, this is something that really needs to be done. We don't know much about what it does to the brain, what it does to growth, what it does to bone mass density. It's not going to be dreadful, probably. If there are any effects, they're probably small, because there's not much seen with it. Having said that, even small effects in large populations would cause difficulties, would magnify. People talk about factors that affect treatment response. I can tell you that the bottom line is that there is no conclusive evidence about what affects treatment response. There's specific symptoms that make the treatment response harder, such as, if you have anhedonia, as in adults, you're less likely to do well if your anhedonia is severe. Then there's stuff about genetic polymorphisms. I'm not convinced about that. I'm not saying that genetic polymorphisms are not important, but certainly not the ones we've found so far. Inflammatory cytokines, maybe, again, no conclusive evidence for that. Growth factors, the same. So pharmacogenetics at the moment is of no help, and I'm just saying this very clearly. Pharmacogenetics in the treatment of child and adolescent depression is something we would really like to have at some point, but it's not there yet, and I wouldn't base any treatment decisions on that, and I can talk more about that if you like. So we talked about the adverse effects of the suicide debate, and I think it's now time to talk briefly about managing treatment-resistant depression. Okay, so treatment-resistant depression in adolescents. So adolescents with SSRI resistant to MDD, there was a trial that was heroically done by David Brent and his colleagues, which is called the TORDIA. And this is very, very important. Okay, so they said, okay, if you've been treated with an SSRI and you didn't respond, right, treatment resistant as I defined it before, then you could switch either to another SRI. So if you had fluoxetine, you could go to citalopram, or if you had citalopram, you could go to fluoxetine, you know, and all that. Or you go and have venlafaxine, and then you could have CBT or no therapy in each one of those two arms. Okay. Take-home messages was there was a higher response rate with CBT than with either medication class switch. There was a similar response rate with a switch to a different SRI versus switching to a venlafaxine. Okay, so people did get better. There was another 40 to 60% response when you switch to a second SRI. However, venlafaxine had a significantly greater side effect burden than SSRIs. And these were cardiac problems, you know, blood pressure and all that. So this is probably one of the most important studies that has been done in child and adolescent depression and psychiatry in general, probably over the last 10, 15 years. So it's important to remember this. Okay, what to do in treatment-resistant depression. So my colleagues and I have developed an algorithm that we've published in JCPP this year. So if you had no previous treatment, then you can have counseling or maybe some group CBT. If you had previous evidence-based treatment for depression, then you could go and have a single pharmacological trial of FDA-approved antidepressant for depression, such as fluoxetine or escitalopram, of adequate duration and at the minimally recommended dose. What's the minimally recommended dose of fluoxetine? Well, it's 20 milligrams, right? So just do that. And now, if a single pharmacological trial of FDA-approved antidepressant for depression of adequate duration has been done at the minimal dose, then give it at the maximal tolerated dose. What's the maximal tolerated dose? Well, it's the maximally tolerated dose. So, it could be 60 for some people, it could be 80. Sometimes people go up to 100, especially when there's comorbidity with OCD. Okay, then you have two trials of adequate duration and dose with SSRI medication. This is what we would do. Fluoxetine, you give escitalopram, hasn't quite worked. Then you can switch to either an alternative antidepressant, an SNRI, bupropion or mirtazapine, for example, or evidence-based augmentation strategies that we know work in at least some adults. So you could give, for example, quetiapine, which is something I often do. Some people give lithium, which is not a bad idea in some cases. And there are obviously other known medications. Sometimes we prescribe stimulants, especially when there's comorbid ADHD that's there already, and we may up it, and it may help. People do it in old age psychiatry, as you know. Then if you've had that and that doesn't work, switch to other augmentation strategies. And you can do, at least 2 augmentation strategies before you declare that you have to go to the next level. And what is the next level? Well, okay, then we come to the realm of what is called a somatic treatment. rTMS, theta burst TMS these days, or ketamine. Okay. How much do we know about rTMS or ketamine in depression? I'll show some slides about ketamine. In terms of rTMS, there's been a recent negative trial that was published in Neuropsychopharmacology, I think last week or the week before, the NeuroNet one. So it didn't seem to work that well. We are starting a TMS trial with neuronavigation and everything. It may depend on a number of issues, but it doesn't seem to have worked that well so far in children and adolescents. It does have FDA approval in adults, as you know. There's at least 2 trials of adequate dose and duration with SSRI medications and all that. And, you know, you've tried your augmentations, you've tried alternative antidepressants, you've tried RTMS and ketamine, then you may have to go to electroconvulsive therapy. I'm very conservative with about electroconvulsive therapy in children and adolescents, and I've been, you know, doing this job with treatment-resistant populations for a while. But, you know, it's an efficacious treatment in certain adults, so it's worth considering if you're at the end of your options. Just a few slides on ketamine. Ketamine does decrease depression scores at day 1. This is a trial that was done at Yale by Jenny Dwyer and her colleagues very admirably. So they gave, it was a crossover trial of, I think, 17 adolescents with ketamine. And the other took ketamine or a placebo, which was midazolam. So mid here is midazolam, all right? And this is the MADRS score, so kind of a score on depression severity score. And what you can see is that people with ketamine did better at the end of day 1 following infusion, which is really a great finding. The effect size was quite substantial with 0.75. And it seems that on average, depression scores remained improved for up to 14 days after the infusion. So you can see this is midazolam and this is ketamine. And I want to thank Jenny for, Dr. Dwyer for providing this information, which is unpublished yet, or still to me to present to you today. And these are the number of, this is a percentage of responders. And I say, just to remind you, responses more than 50% decrease from baseline depression score. And you can see that there was those who responded to ketamine only are eight people, 5 who responded to both, and there's only 1 person who responded to placebo only. So, you know, it seems to be doing something. There's a whole discussion we can have about ketamine and how easy it is to blind ketamine and the treatment of ketamine. And there are some unique challenges there. As you know, there's at the NIH, there's a new drug being tested that is based on metabolite of ketamine, hydroxynyl ketamine. This is by Dr. Carlos Zarati's group. So we're very excited to see this being tested, not least because we will have, this is apparently a compound that doesn't cause the dissociation that can lead to the unblinding. So I would like to have some time for discussion. So I presented to you about depression, definition and challenges in children and adolescents. I gave you an overview of the treatment and talked more in depth about the efficacy and the placebo effect. I spoke a little bit about proposed mechanisms of actions and how we must take these still with a pinch of salt. And I mentioned the adverse effects and the suicide debate. And I talked to you about managing treatment-resistant depression, at least the basic principles of it. With this, I would like to thank very much the organizers again for the honor to have been invited to present to the WPA today. And I'm here to take any questions that might have arisen during my talk. Thank you.
So thank you, Professor, for this outstanding presentation. And I would like to thank for your time in this very early morning and sharing with us your knowledge, your experiences. Also, our audience also wants to express the compliments. And we also have the few questions, if you allow me to read them. So a colleague says, wonderful talk, highly informative by a great speaker, excellent presentation. So thank you, Professor. So, and Professor Mohan from the United Kingdom asks you, if you are using ketamine off-label in adolescents, will you consider using a licensed treatment in adults, such as ketamine nasal spray off-label in younger patients with treatment-resistant depression?
Yes, this is an absolutely excellent question. I'm indebted to Professor Mohan for asking me this. I would start by saying ketamine should only be prescribed by someone who knows what they're doing and where they're doing it. So you should be doing it with great caution. You should have a clinic that is dedicated to doing ketamine infusions. You should have an anesthetist. You should have an anesthesiology nearby at the very least. and I think this is extremely important for safety, particularly in the beginning. Now, I acknowledge the fact that ketamine has been used in pediatric anesthesia for decades, but still we're using it for a different indication. So I think we must be very careful. Now, if I were to do this somewhere new, I would start with the IV infusion option, because we have most data on that. It is cheaper. We have most data on that. We know that the bioavailability is not affected by, you know, having asthma or whatever else. So I would personally do it this way. I could also totally understand it if people wanted to switch quickly to the spray, because, you know, it's not that all young people love being infused with a drug, of course. But I think that for the time being, I would be more conservative in that and just do the just do the IV infusion. To be honest, under very careful conditions. That's a very good question, though, and thank you very much.
So thank you for your response. And Dr. Paresh Khan, sorry if I pronounced not in the correct way, asks you what precautions we should take for ketamine treatment in adolescents.
I think I answered this question partially already. I think the most important things to do is to make sure that they're really treatment refractory, right? That they're really not doing well. Because often what happens is I get cases where they say, oh, treatment-resistant depression. And then you go back and you say, okay, fluoxetine was prescribed. What dose? Oh, 20 milligrams. Okay. And how long was it prescribed for? Oh, 1 week. And then it was stopped. And then, you know, so you really need to go back and make sure that it was done the proper way, that really this algorithm that I presented has been followed. And if it hasn't, you need to do that. So that's the biggest precaution I would take. The second thing I would say is, there aren't a huge number of absolute contraindications to ketamine, but you know, ketamine has a propensity to cause hypertension, for example, right? So you do want to make sure that you check the blood pressure, you do pre-ketamine hypertension check, and that the person you're treating is medically fit. And I hasten to add this, unless you yourself are fantastically well trained in intubating and doing all this, I would have an anesthetist nearby, or someone who knows what they're doing in that regard if things were to go wrong. At least in the beginning, as people are gaining experience. All sorts of other precautions as well, you know, which go without saying, like making sure that you draw the right dose, especially if you don't have a special clinic and all that. All this is important. There's also psychiatric side effects. So if you've ever given ketamine to someone, you will know that they know that you've given them ketamine, right? So there is unblinding going on. That's one thing. And the second thing to say is that people can get quite emotional with it because of the dissociation. So you must be prepared to deal with that as well during the infusions. And of course, we're better trained to do this as psychiatrists.
So thank you for your response. We have to strictly respect the time. Kostas, do we have a minute for questions, or we have to proceed?
Well, I think we need to proceed because at 2 o'clock we need to stop.
Okay. So thank you so much, Professor, again.
Thank you very much.
So, and now I would like to introduce Professor Konstantinos Fontolakis, who is a professor of Aristotle University of Thessaloniki, a happy university hospital in Thessaloniki in Greece. So areas of clinical and research interest are reflected in the topics like general psychiatry, biological psychiatry, psychopharmacology, personality disorders, mood disorders, and many others. So he has co-authored more than 400 papers, and his Hirsch index is more than 45, which is very impressive. So he has authored and co-authored number of books. So I also would like to mention that Professor Fontolakis received important research awards, including Kraepelin Alzheimer's Medal and also Excellence in Education Award of World Federation of Societies of Biological Psychiatry. So this is only a part of the list of his professional activities and achievements. So Professor Fontolakis, please.
Thank you, Lena. Hello to everybody. For some is morning, for others is evening. I'm going to talk about evidence beyond evidence-based psychiatry and treatment in bipolar disorder. And what is beyond evidence-based is how close we can go to precision and personalized psychiatry. And the example will be the treatment of bipolar disorder, how the landscape of the data is and how we can have a reliable and valid decision making. If we see the historical development and evolution of medicine and psychiatry, in most specifically, we can see that from more primitive pre-scientific era with shamans and magicians and priests, we went on to the unsystematic development of medicine in the 16th and throughout the 19th century. And the last 2 or 3 decades, we are in the evidence-based period, which is not here yet, but it's fast advancing. And what does evidence-based mean? It means that you need to gather data in a systematic way. You need to scrutinize the data. You need to be very hard and strict in the interpretation. You need to confirm and to replicate. And if and when this goes well, then you can have subgroups with more precise diagnosis, more precise treatment, and eventually the aim would be to have diagnosis and treatment tailored to the individual person. The individualized approach, not in the sense of psychoanalysis, which is individualized but not evidence-based, but in the sense of knowing, as hard science only knows, what's best for the treatment of this specific person, which is probably out of our reach to be able to have absolutely individualized diagnosis and therapy is probably against the methods and the abilities of science as we know it today, because we are based on reductionism and on data gathered by groups. So yes, we can have smaller and smaller and smaller groups. We research and we gather knowledge, and we can apply very precise treatment for all the smaller groups, but probably we will never be able to have truly individualized diagnosis and treatment. As I said, we can go from large heterogeneous groups to more homogeneous and smaller groups, and this process will go almost eternally. Personalized and precision medicine is not something new. It came from the era of Hippocrates and went through Claude Bernard and Archibald Garrod until today with the most modern ways of imaging and genetics and information systems. What evidence-based medicine asks is for the conscientious, explicit, and judicious consideration of the data and the integrating of these research hard data into the everyday clinical practice by fusing it with our clinical expertise, which is currently not able to substitute with any hard science or hard research data. So we need to have clinical excellence on the basis of integration of research data and clinical observation and experience and wisdom. What's in favor of personalized medicine is that it is precise, it is reliable, valid, and it is accepted by patients because it gives them a sense of personal value. What is against is that we have some kind of uncertainty. We need to utilize trial and error strategy, at least currently, We have predictions based on group statistics, which do not apply always to the individual person. And this is the common practice we exert. That is, we try to translate group findings into a personalized, individualized approach, which is not always easy, and probably it's not always reliable or valid. What are the tools we have today? Well, as Argyris showed, we have very little knowledge on the deep structure, genetic or neurobiology of major mental illness, including schizophrenia or major depression. We have some good idea that there are some systems that malfunction, but still the real data are conflicting. And the most pessimistic of us suggest that we are still where we were 70 years ago, just before the development of antipsychotics. We haven't made a single step forward. That's the most pessimistic opinion. Probably it's too pessimistic, but it reflects a gap, a huge gap in our knowledge. What happens when you find something that that helps the everyday clinical practice, and we don't have such a tool right now, such a marker right now, is that it change the paradigm. It does what Kuhn described in his cycle. It induces a paradigm shift, a model drift, which leads to model crisis, and a change in the way we conceive diagnosis and treatment. That's a paradigm shift. For example, electroencephalogram created a paradigm shift in neurology, because it was much easier and much more reliable to identify persons with epilepsy, and then it was easier to research and develop medication treatment. So electroencephalogram was a tool that induced a paradigm shift. We don't have still such a tool in psychiatry, and it is something we need to obtain urgently. Now, what is psychiatry? Is it an art or a science? Well, I won't go in detail with this thing. I have extensively lectured about the problems we have with the traditional psychoanalytic and psychodynamic approach to psychiatry, which is of low reliability and low validity, with a lot of eminence-based approaches and teachings, like the Hofmann by Freud. What we need to have in mind is that as physicians, as therapists, and not only psychiatrists, but all mental health professionals, psychologists, speech therapists, social workers, every mental health professional must have in mind that we are dealing with patients who have specific needs, and they come to us for a specific reason. We are not philosophers who just think for themselves and they try to fill their own gaps. We respond to crises other people suffer from. So we need to be disciplined. We need to apply standardized and reliable ways of treating them. We need to restrain our emotions and to think, to have knowledge, not common sense. We are not common lay people who try to deal with problems in our neighborhood. We are professionals. We need to provide professional and reliable responses and solutions. We need to have expertise. Today, authority and eminence is not the answer. Expertise and evidence are galloping towards domination in this field. But for psychiatry, the question is whether this evidence-based and precision thing is an oxymoron or an utopia. there is the existential argument that says that, okay, we cannot have, in mental health, we cannot have this evidence-based and precision uh, narration because mental illness and mental states are of a different quality. But if this is so, then we are not scientists. We are loose philosophers, and we cannot really respond to the um, demands, to the needs of mental patients in dire conditions. Of course, there is the methodology argument that mental states are very, very, very complex. So our approach, our research approach is by definition and for practical reasons, very naive and very simple, very simplistic in comparison to the real complexity of the phenomena we're trying to study. Yes, so this methodological agreement is probably right, but we need to follow this pathway towards a deeper knowledge and the development of better care for our patients. So probably psychiatry is between the unsystematized medicine and the evidence-based medicine, trying to find its way towards evidence. We are far, far, far away from precision. The basic issues in evidence-based psychiatry is the randomized placebo-controlled trials. These are absolutely necessary, especially because there is a high placebo rate, as high placebo response rate, as Argyris very in much detail pointed out. So mental disorders have a fluctuating course and a lot of sociocultural and personal factors affect this course and this response. So a placebo is absolutely necessary. And if we don't use a placebo, then we will end up treating our patients with options that are hardly efficacious. And placebo-controlled trials are always blind. Double blind is absolutely necessary. Single blind is not adequate. Blindness means that we don't know what our patient is receiving, so that we can rate the response in an unbiased way. And then we need to have a predefined primary outcome. This means that before we start with the trial, with the research endeavor, we need to predefine that, okay, this is what I'm going to see. Of course, I can assess a number of other things, but these are secondary, because if I do not predefine what I am going to rate, then I take ratings from, let's say, 20 variables, and then I cherry pick, I select in an arbitrary way the one that makes a significant difference. So I report only significantly different results, and this is biased, if not a fraud. So these three are the three pillars of evidence-based psychiatry. It is also of evidence-based medicine, but for psychiatry they are absolutely necessary because we do not have biological markers. If you have a patient with diabetes mellitus, you can easily assess blood sugar, but there is no such, and this is very objective, but for us, there is not such an option. Now, following these guidelines, these general ideas I described, in the CIMP, we tried to develop guidelines for the treatment of bipolar disorders. You can see here the work group. We worked for more than 3 years on this task. This was a very, very, very difficult task because the data were very complex. You can see this meeting in Berlin. You can see the devastation and the embarrassment in our faces when we were trying to figure out how we are going to make sense of this chaotic environment of data. You can see that only Zivk was happy enough to take a selfie. And eventually, we realized that we should take into consideration a few things like clinical wisdom, as it is, for example, in the Plachnik cone of emotions, that emotions can, when they are very weak or very strong, they can switch from each other, shift to each other, that we have a very complex clinical picture in the long term for bipolar disorder that includes mania, includes treatment emergent affective switch. It includes side effects that look like a relapse. It includes a lot of things that you need to take into consideration when you try to make sense out of the data. And you also have cognitive disorder, which complicates the, you can see here the effect size of cognitive decline in bipolar depression in comparison to euthymia and to endophenotype. Endophenotype is what you see in relatives. On average, the patient with bipolar disorder has 0.8 effect size of cognitive decline, while in schizophrenia it's 1.2, and in major unipolar depression it's 0.4 to 0.5. So it's in between schizophrenia and unipolar depression. You have comorbidity with alcohol, substance abuse. You have psychiatric comorbidity. No patient with bipolar disorder has only bipolar disorder. They also have anxiety, panic. They have eating disorders, etc. They have medical comorbidity twice as in comparison to the general population with obesity, dyslipidemia, 100 times more often they have endocrinological disorders. Of course, they have hepatitis and AIDS because of probably because of substance abuse. They have migraine and cardiovascular disorders. We're dealing in bipolar disorder. We're dealing with a constellation of symptoms that range from the very common mental symptoms like anxiety to the very rare somatic disorders like hepatitis or liver disease. Taking all this into consideration, bipolar disorder is one of the leading causes of disability in terms of disability adjusted life years for ages below 50 years. And it's probably in the first 2 or 3 if we take into consideration that many of unipolar depressive patients are, in essence, they are bipolar, but they haven't experienced a manic episode yet. What we did was to sweep the entire literature with the PRISMA method. This is the PRISMA flow chart. To the left, you can see the sweeping of the literature concerning randomized controlled trials, and to the right, the sweeping concerning guidelines. You can see that we started with 3,592 papers on randomized controlled trials and almost 2,000 papers for guidelines. We developed a new grading system because existing grading systems were not what we could utilize to grade such enormous data of such complexity. We needed to have a grading system to decide what happens when you have, for example, more randomized, more positive than negative randomized trials, but still mixed results. So we had 32 scenarios, and we graded these scenarios. We ranked them, and eventually we developed a grade system like this in terms of efficacy, that we needed at least 2 placebo-controlled trials to have a level 1 efficacy. And then the next thing was to have a grading system in terms of safety and tolerability, which was even more complex in terms of concept. For example, what's more important? Is it tardive dyskinesia that haloperidol causes, or the risk of death caused by clozapine? Because since the 70s, we have no death because of clozapine, which means that for clozapine, if you monitor the patients adequately, the real risk for death is rather theoretical. It's not real. but the risk for tardive dyskinesia is quite real. So we had endless discussion, and eventually we had a compromise. We both put them at level 2. So this is just to show how difficult it is sometimes to uh, to follow the evidence-based idea. You don't always have a rule what's evidence-based and what you mean by this and how you describe this. And eventually we had a method of recommendation by combining the efficacy and the safety tolerability grading methods in 5 levels. The 5th level is not recommended. We had this chart, which is extremely complex, chart of all the treatment options at the left first column, and then we had these clinical facets: acute mania, acute bipolar depression, mixed episodes, and the maintenance phase. And we graded each of these treatment options in terms of efficacy and tolerability. You can see that dashes are more than numbers, which means that for this table, the lack of information is much more than the existing information. And this is the gap of knowledge we have. For example, we don't know, for example, whether aripiprazole here, which is overall efficacious in acute mania, we don't really know in terms of evidence whether it treats core manic symptoms. We don't know if it treats agitation. You have a dash also in agitation. We don't know how it does with carbamazepine, lamotrigine, or lithium. Specifically, we know that, okay, you can add a mood stabilizer in general, but we don't know exactly what which mood stabilizer is the most suitable. So we have a lack of knowledge concerning a lot of things, but we do know we do know that this specific agent works. We know that liscarbazepine has a 5, which means it's not recommended for acute mania. So this is the matrix of our evidence-based knowledge concerning the treatment of acute mania. Dashes are far, far more than numbers. We had a list of clinical aspects and issues of manic depressive illness, and we found out that only for those in red characters, we had some data from hard evidence-based designed trials and research. We had no data, for example, for sub-threshold, how to treat sub-threshold symptoms. We had no knowledge how to treat cyclothymia or personality-like behavior, neurocognitive disorder, or drug or alcohol abuse, or suicidality. We can only use our clinical wisdom to treat these conditions. So the question is how close we were with this very, very, very scrutinized way of interpreting the literature and validating the outcomes. How close are we to precision medicine concerning the treatment of bipolar disorder? For example, let's say we have a patient that is in an acute manic episode. He has psychotic features, and the long-term course is that of a rapid cycler, has at least 4 episodes per year. At best, we can have a 3 for psychotic symptoms and a 3 for rapid cycling because the data come from post hoc analysis, and post hoc analysis are not as reliable as the primary outcome because they can be selectively reported. So if we take this matrix, we can see that the combination of efficacy on overall acute mania, on psychotic symptoms specifically, and rapid cyclers give us three options. That's aripiprazole, olanzapine, and quetiapine, and that's all we can have at this time, which is not a bad idea to start with, but the data are not as good as we would like, because you can see that there is too much uncertainty because of publication bias. And then we went on to create a more practical algorithm, because the use of such a big chart needs that you dedicate one of your walls to print out this chart, and then you try for every patient to find the combinations, which is very difficult. So we went on to have a more simplified way to treat bipolar disorder by phase, and this is the acute manic phase guideline. For all cases, you discontinue treatment with antidepressants. When he's a rapid cycler, you start with aripiprazole, blah, blah. When you have a mixed features, then you start with quetiapine or risperidone. When you have a mixed episode, you always start with a combination. That was really new as an idea, that you need to start a combination when you have a mixed episode. You cannot start with monotherapy. And this is the first step. The second and the rest of the steps, they are very complex. If you are interested, you can go to read the paper, because it makes no sense to describe them right now. You won't remember a thing tomorrow morning. And this is the acute bipolar episode algorithm. You start with quetiapine or lurasidone and go on with the rest of the steps. And this is the maintenance phase. Depends on predominant polarity, whether your patient tends to relapse into depressive or manic episodes, whether there are frequent mixed episodes in the long-term course, whether he is rapid cycling. And what is really important here is that the hard data suggests that for rapid cyclers, during the maintenance treatment, you can start with lithium monotherapy. To be more specific, you should start with lithium monotherapy, which is very new and in contrast to what we were normally teaching in our everyday teaching of residents and etc. So and also we went on to have an even more simplified algorithm with first, second, and third step in a very, very user-friendly format. The previous was for acute mania. This is for bipolar depression. But the most important thing, I will bypass all this in order to, here is the publications you need to have in mind if you want to dig deeper into this lecture. What is important is whether we can use all these things to tailor in real time treatment of patients. And what we did, because as I said, the chart is so complex that you need to dedicate a wall in your office. And after the second or the third patient, you will never use it again. So we tried to develop a software, and really it is available now, both in Android and iPhone formats. You can go to Google Play or to iPhone, to the respected iPhone site, and you can download the CIMP bipolar treatment guidelines. It is for free. You can install it in your mobile phone, and you can check what is your patient. He is in an acute episode, acute manic episode. You can check this, and you need the overall efficacy, and you need to treat also psychotic symptoms because your patient is psychotic. And then you press OK, and you have all the agents that are recommended, and more important, what it is not recommended. Like this. I think you cannot hear the narration of the video, but you can see how the screens change. There are all available information inside this application, all the papers and all the biographical information of authors. You can see now the cascade of of actions and how you can use this specific application. There is a spin-off menu that explains what overall efficacy means. It means that the applications with return treatment options on the general clinical picture of the manic episode. So you can download this. Application and check it by yourself. We think it's very helpful in the everyday clinical practice. It's very user-friendly. It might make the life of department directors and professors very difficult because residents might use them and say, okay, professor, this is not what the evidence say. But still, it's a step forward. Thank you for your attention. Lena?
So thank you, Kostas, for this wonderful, very up-to-date and comprehensive presentation. So, and this also audience say compliments. Unfortunately, I can't find any questions exactly to you. So I think we can proceed if there are no questions at the moment. So, and the next, I will ask our discussants to give a small comments on the lectures. And first, I would like to ask Dr. Kishore Guyar, who is a president of Indian Association of Child and Adolescent Mental Health. He also is a certificate course in child and adolescent mental health, mentally handicapped. So please, Dr. Guyar. You have to on.
Hello.
Yes, we hear you.
Organizer for giving me this opportunity to be discussant for this program. This was a wonderful program. Both the presenters have done an excellent job. Specifically, Argaris has given a different perspective. It was very thought-provoking and very stimulating. We need to further interact with him ongoing, and we can arrange such a program so that we'll have a more understanding about the psychopharmacological treatment in a child and adolescent client group. Additionally, the next speaker have given a comprehensive highlights about the mood disorder management, very given a lot of information which was not there with most of the delegate, and that will be definitely helpful. Whatever the different softwares he has discussed and included, that will definitely help the people to navigate different aspects of the mood disorders and selecting the proper molecule for a particular client. Thank you once again all for giving me this opportunity to be a discussant for this program.
So thank you, Dr. Guyar. And I also would like to say a commentary to Dr. Josephine Omondi, who is a child and adolescent psychiatrist providing clinical services and teaching for at least 17 years, stationed at the Kenyatta National Teaching and Referral Hospital in Nairobi, Kenya. So, doctor, please.
Hello.
Hello, we hear you.
Yes. Thank you very much for giving me this opportunity to participate in this first regional symposium. I'm also very happy with and impressed by the two speakers who took us through the management of major depressive disorder or depression generally, and also bipolar mood disorder. Now, in a general perspective, in a broad perspective, I think we are still very far with regards to the management of, evidence-based management of children's problems, children and adolescent mental health problems. But we are reaching somewhere because there has been a lot of new developments. But when it comes to managing these children, I think there are other areas that needs to be looked at. And I know the first speaker talked about comprehensive assessment of the patient, so that you can have a clear understanding of the problem, and therefore make a clear decision with regards to the treatment. With children and adolescents, it's also important to look at the neurodevelopmental psychopathology. It is very key for anyone to make a proper diagnosis. But having said that, there is also the other component that is not very clear, that some of the problems like depression seems to be a continuum until such a time that it creates a dysfunctionality. And so sometimes it's difficult to tell whether to start when to start the treatment, and whether you just observe, as the first speaker had said. As to the management of bipolar disorders, I think I'm really happy, but we are still very far again in having conclusive evidence with regards to managing children and adolescents. But for the adults, it's really not a big issue. So I would sum this by saying that we still don't have clear biomarkers, and we still rely on maybe more of diagnostic markers, like looking at the extensive moods, looking at the dysfunctionality, and also the genetic markers. But we still don't have very clear evidence that we can use, and therefore we still depend on a lot of the environmental and multifactorial causes or contributors to the problems. But all in all, I'm very happy, and I think I don't have much to say, and I just want to thank you for giving me this opportunity. Thank you very much.
Oh, thank you, Dr. Amondi. Kostas, do we have time for one question to you?
Yes, of course.
Mm-hmm. Dr. Paresh Schach is asking you, what is the role of lithium in children bipolar disorder when it should not used?
But it's not for me, it's for Argyris.
For Argyris, oh, pardon.
Because it's for children, right?
Yes, it's for children, exactly.
So it's for Argyris, are you here? I think he left.
Yes,
it's very early in the US. I'm not sure what I'm not sure what the place of lithium in children would be. Lithium is a very peculiar treatment option. It's very efficacious in a minority of patients. It's so efficacious in this minority to the extent that you say, okay, these people suffer from a lithium deficiency, which is not true, of course, but it's so efficacious. They completely recover that you think they suffer from some kind of lithium deficiency disorder. The problem is that in the long term, we don't really know what's going to happen with these people, especially when lithium is combined with typical antipsychotics. Many people have toxic phenomena, even even under normal lithium dosages and therapeutic plasma levels. So it depends. For children, I couldn't say. For grown up adults, it's surely a very good first choice, especially when people have a complete remission under lithium. If response and remission are not complete under lithium, then okay, you might reconsider it. But for those who have a complete remission, I doubt that you can achieve this complete remission with other agents. So it's a tricky treatment option. Very, very useful, very powerful, but you need to be careful and know how to use it. Okay.
Yes, thank you, Kostas, for your commentary. So colleagues also are asking to type the full name of this application. Could you please do it?
It's CINP. Just give me just give me 1 minute. I will show it again in full screen. Okay, this is it. There are two CINP applications. The one, three. One is on the nomenclature. The second is for the CINP Congress, and this is the treatment guidelines CINP application. So if you go to Google Play and type CINP BD treatment guidelines, or to the respected site for the iPhone, you will see this screen and you can directly download.
Okay, thank you. So as this webinar became possible also because of involvement of Pan-Hellenic Medical Association, I'm kindly asking the president of this association, Dr. Athanasios Exadaktilos, who is a plastic surgeon, so we have multidisciplinary our audience here, to say some words about our webinar and organizational of the webinar.
Thank you very much. It's an honor and pleasure for the Pan-Hellenic Medical Association to contribute in this event, which I attended partially, despite that I'm a plastic surgeon, not a psychiatrist. I'd like to thank Dr. Foundoulakis for all the good work he does, as well as the Professor Tristrigaris for the lecture and all the participants. It's very important in COVID-19 era to continue our scientific meetings despite the difficulties and grace to technology. The importance of evidence-based medicine is, of course, of paramount importance in all aspects, and would be unnecessary to keep talking on this. Therefore, I'd like to congratulate all, and hopefully we'll meet soon in the future. Thank you.
Oh, thank you, Doctor. So, Kostas, do we have a small time for one of questions?
Of course.
Yes, we have timing. So, under what circumstances will you consider continuing lithium in pregnant women?
Well, that's a hard question. That's a very hard question. There are some guidelines for pregnancy, and for lactation it's minor. The problem is minor for lactation. For pregnancy is the big problem. So there are a number of guidelines. I will tell you my own opinion. All the agents we have and are anti-manic or antipsychotic are essentially lowering metabolism. The same holds for anti-epileptics. They lower metabolism, cellular metabolism to some degree, which means this has two consequences. The first consequence is that when you have an external insult, for example, a stroke, and you're receiving such a metabolism lowering agent, then the insult has reduced impact. This is why some of these agents, including lithium, are considered to be prophylactic. The same thing has a dark side, which means that when you have a developing organism, you need to be very careful when you're giving such agents. Now, when a kid has a bipolar disorder, you will treat it because it's not a normal physiology. So you will give lithium or antipsychotics or whatever to a kid that suffers. But when you have a pregnant woman who suffers, this does not mean that the fetus suffers also, which means that this agent might have some unknown consequences to the fetus. And probably for the first trimester, you should not give any medication treatment to any pregnant woman. It's not so strict for the second, and it's rather loose for the third. For comparison reason, I tell you that neurologists never stop antiepileptics during pregnancy. So we might be too strict in our guidance of not giving medication to pregnant women, but still it's a matter of debate. My personal approach is that I educate couples who want a child and the female is under treatment. This rarely stops them. I rarely continue medication. I try to stop them. With lithium, it's very tricky because you could have a lithium discontinuation refractoriness, which is probably not true, but still it's something you need to have in mind. So I really don't have an answer there. I wish I don't face women who are under lithium and want to become pregnant. It's a very difficult decision. I think it's up to them to decide. You cannot decide for themselves. And also it depends how good they respond to and what's their previous history. If you have a partial response to lithium, the question is whether they should become pregnant. if they have a full response to lithium, then probably you should not stop it. Still, it's an art, right? It's not evidence-based, it's an art. Okay.
Thank you, Kostas.
We don't have much time.
We don't have any time anymore, unfortunately. So then it means that we have to finish. I would like to thank, first of all, World Psychiatric Association, all representatives who have found the time to be with us here. I would like to express my deepest gratitude to all speakers, sharing really high quality lectures. So, and in these difficult times, despite the fact that we don't have opportunity to see each other and discuss to each other face to face, so we still are able to obtain high quality and evidence-based knowledge. And finally, I would like to thank every participant who is here. So on Saturday morning or afternoon, and thank you again for being with us.
Take care, all of you, and stay safe. Bye-bye.
Thank you.
Thank you.
Bye.